So I'm going to talk about genomics and AMR, and particularly the social science lessons that we can derive from the application of genomics to HIV, which is already being underway. I will establish a sort of parallel between HIV and AMR genomics and the technologies and situate them within the larger policy and moral economies similar to the previous presentation. So I will first explore the relationships that exist between what AMR genomics promises and what actually are the structural, the social, and the data inequalities that underpin genomic deployment in the case of HIV. And then I'm going to consider a particular example, which is the use of HIV molecular epidemiology to explore the kinds of knowledges and the kinds of interventions that are identified as benefiting from using genomics in this context, and provide some ideas for the future. The sort of core argument I want to pitch to you today is that technologies like genomics are never neutral. They embody the priorities that are they embody priorities in sort of science and policy, and they create new forms of knowledge and power that are likewise not neutral. From HIV and the application of genomics to HIV, we have already learned that optimism over the power of new technologies tends to foreclose the possibility of sensitively understanding the new practices that accompany their application. And this is sort of what I'm going to be talking about today. So let's start with the technological promises. The field of HIV, for any of us who have been working on it for a few years, is marked by astonishing technological progress. We have better treatments, new prevention modalities, new biomedical interventions such as PrEP and long-acting treatment, and there's ongoing research on vaccines and cures. All of these developments have saved millions of lives and have massively reduced suffering, so they are great. But at the same time, we have also seen a very consistent pattern, which is that technological solutions, such as vaccines or more refined treatments, have been for granted, while the social drivers of HIV, which are essentially poverty, stigma, criminalization, discrimination, and unequal access to basic prevention and care, remain under-addressed and under-researched. In a similar way, I would argue that the promises of pathogen genomics that involves sequencing the entire genetic material of a disease-causing organism can supply incredibly useful epidemiological insight, as we have seen from the presentations today so far. They can help us pattern the spread, the resistance, and the trajectories of pathogens. And they promise earlier detection of resistant clones and the potential for more targeted infection control. But the truth is, as the presentation has emphasized, that AMR resistance is not distributed evenly around the globe. In a 2015 Lancet series on drug-resistant on AMR, the key or a key finding was that drug-resistant bacteria were associated with a huge mortality burden, but that burden falls disproportionately on low and middle income countries. AMR thrives when there are overlapping deficits, inadequate water, sanitation and hygiene, overcrowded living conditions, poor infection prevention and control, limited access to high-quality antimicrobials, and systems that poorly regulate the use of antibiotics. So when we think about large visions of genomics solving AMR, we must definitely ask, solving what exactly? Solving it for whom and with what trade-offs? If the core drivers of AMR are poverty, the lack of WASH, so safe water, sanitation and hygiene, weak health systems and poor governance, the sequencing of genomes will not by itself change those conditions. In fact, we know, according to modeling, that by just centering efforts on expanding access to infection prevention and control, including WASH, so water, sanitation, hygiene, and vaccines, existing vaccines, we could prevent almost 20% of AMR-associated mortality in low and middle-income countries. So the conclusion is, I think, quite simple. Some of the most effective interventions we have against AMR are not shiny new genomic platforms, but are investments in basic public health and social infrastructure. This brings me to another worry, which is data equity. Genomics generates vast amounts of data, but data are not neutral and their benefits are not distributed equally across society. There is a political economy. By this, we mean a series of priorities and biases in how data is distributed. Because sequencing infrastructure, the labs, the training, the secure data storage that is needed is concentrated in wealthier countries, but the heaviest burden of AMR is elsewhere. It's in lower and middle income countries. This mismatch can produce very extractive patterns. Samples and sequences that are generated in one place, the analytical capacity and the consequent benefits, such as insights, new diagnostics, new treatments, are in a different site. The real risk is that genomic solutions will be designed in wealthy settings for wealthy contexts and wealthy populations, but it will be lower and middle income countries that are left to be surveyed and extracted time and time again for no benefit to them. We must think of capacity building, data governance, and sharing the core elements of genomic programs. So if we have seen that the promises, and so far have been quite pessimistic in a way, but also that's part of social sciences, perhaps, but we have seen how the promises of AMR may sideline the urgency of structural factors and social inequalities, and also the issues with data equity. So then what can genomics actually do? And I would like here to focus on the case of HIV molecular surveillance. So molecular HIV surveillance, or MHS, has been promoted as a key way to detect transmission clusters early on so that public health practitioners can intervene in a very targeted way and interrupt onward transmission. It has been deployed extensively in the United States, which uses this idea of cluster detection and response as a major component of their national strategy to tackle HIV. Whether that is still the case after Trump's White House is unclear, but it was until very recently. And MHS, or molecular HIV surveillance, has been embedded as a key driver to reduce, or a key way of reducing new infections. Yet this promise has quite real, concrete harms and controversies that have not been addressed very well, with the exception of this piece by Muldrum and Smith. First is the issue of consent. In the United States, molecular HIV surveillance is conducted on data routinely collected, samples routinely collected from people living with HIV without explicit informed consent as to how those samples are going to be used. They are collected for resistance analysis for treatment, but they are not told that they're going to be used for tracking epidemiology. This repurposing of samples raises quite important ethical questions that science alone cannot resolve. If people do not trust the system with the samples and their data, then these surveillance programs can actually not only not contribute, but actually undermine the public health relationships that they need. The second issue is one of privacy and criminality. Genomic data, however they identified, even if de-identified, rarely exists alone. Muldrum and Smith argue that HIV sequence data is almost always embedded in metadata. Dates of diagnosis, clinic identifiers, location, and demographics, among others, because it's this metadata that makes genomic data useful for surveillance and targeted interventions. But it is also this metadata that makes genomic data re-identifiable, and it can be used, therefore, in contexts that can harm individuals. The clearest example here is how HIV phylogenetic analysis have been used in criminal proceedings and have been discussed as tools to identify likely transmitters of HIV. There is broad consensus that phylogenetic data cannot infer directionality of transmission. But these nuances are almost always lost to courts and media, to the extent that it has been argued in court successfully that it can infer directionality. The third issue is one of stigma. One of the most seductive features of genomics is its granularity, right? We have seen in the presentation here, we can detail which sinks are at the heart of an outbreak. It also allows us to say things about the relationships between cases with very clear, very precise understandings. But that granularity, when applied to people, can be quite threatening. The more precise our maps of transmission pathways are, the more likely it is that such maps will read as moral or legal indictments. You may say that AMR is different because, unlike HIV, it is not defined by a stigma. But we all remember quite early on during COVID when super spreaders were very quickly stigmatized. Stigma is not unique to HIV. It is very sticky, it is very prevalent, and it can attach to almost anything. And we can all imagine ways in which AMR can be stigmatized. In HIV, being framed as a node of transmission cluster can lead to blame, policing, or other punitive responses. And technologies that promise more precise knowledge can therefore increase our stakes of visibility. More knowledge means more power, but also potentially more harm. On all these threats, the thing that I am most concerned about is that are most likely to apply to already vulnerable communities. In the case of HIV, this means people engaging in sex work, trans people, LGBT people, and Black and brown bodies. As Black and Bernard insightfully comment, practices of molecular surveillance must be situated in understandings of the historical and ongoing ways in which data has been weaponized in racist, classist, misogynistic, homophobic, or transphobic ways. So these questions are not foreign to AMR genomics, they are central. How do populations, which populations are most likely to bear the burden of surveillance? And then the last question we'd like to raise is one of logics of knowledge and intervention. So in the case of HIV, so what kinds of knowledges does genomics promise, and what kinds of interventions does it offer to facilitate? In the case of HIV, genomic surveillance promises new, more efficient, more real-time granular knowledge. So early detection of outbreaks, data-driven targeting of communities. There's a really interesting example from Ragonet and Cronin et al. Describing a 2019 study in which they conducted genomic surveillance analysis of transmission networks of HIV among transgender women in LA, in California. They argued that genomics might be more likely to identify additional transgender women with HIV or at risk of infection than usual partner services, and that they would provide more accurate, granular, and productive ways of identifying those partners than ongoing practices of partner elicitation, which means sitting with a person who has been diagnosed and asking them about their partners to get in touch with them to test them. But many concerns were raised about this paper, including that approaching people as vectors of disease and not as people is quite problematic. But I'm very interested here in the issue of knowledge. In a very, very good response, Chang et al. Argued that the study results were already well known to most people working on HIV at local, community, and academic levels in California. Essentially, the study concluded that transgender women were at higher risk, that their networks were different to those of gay men or men who have sex with men, and all of these are not new. So all this genomic data, all this violation of consent provided data which was in no way new. And in fact, what this study did not do was provide any insight into why these transgender women were out of the reach of public health authorities, why they were why they were not accessing testing, why they were not accessing services. That is what genomics cannot provide either. So genomic promises new knowledges, but much of what it promises actually is replicating what on the ground and activist and academic communities already know, ignoring actually the social and contextual knowledges that are essential. And the logic of intervention that it promises, or the kind of interventions that it promises, are sort of obscuring the necessity for political will to dismantle the structures and the inequalities that make those communities be at higher risk of HIV. So in a way, AMR genomics may tell us where resistant strains are circulating, but it will not, on its own, build water infrastructure, transform markets for antibiotics, or eliminate the social conditions that produce high infection pressure. I had some ideas about thinking about the future, but potentially I'm going to skip that for the sake of time. I'm going to simply say that genomic technologies should be treated as tools within a larger policy and moral context. They are powerful, but their power is shaped by our choices. Choices about governance, distribution, and priorities. If our goal is to reduce AMR equitably and sustainably, we must insist that genomics be paired with investments in the social determinants of infection, with governance structures that protect those most vulnerable, and with equity that allows for participatory models of data stewardship. Thank you.